Hello, my name is Dr. Lisa Rosano, and I'm Associate Professor of Psychiatry at the University of Illinois at Chicago. Joining me today is Nicole Pashka, Program Coordinator at Thresholds, a large psychiatric rehabilitation agency. Today we're going to be talking about cultural mindfulness among sexual minorities and gender non-conforming populations in the workplace. It is important to recognize that there are some striking disparities in mental health care that can be found for cultural, racial, ethnic, sexual, and gender minorities. The goal of this session is to introduce some skills and ideas that will support practitioners in improving responsiveness and mindfulness around these types of differences. We will try to build capacity among participants to reduce prejudices, stigma, discrimination, and microaggressions that could affect them in their communities and particularly in the workforce. We would like to acknowledge the funders that make these programs possible: the Center on Mental Health Services at the Substance Abuse and Mental Health Services Administration, Thresholds and the contributions of Melissa Sherman, the UIC Center on Mental Health Services Research and Policy, and to just remind our listeners that the views and ideas expressed here do not necessarily reflect policies or positions of any federal agency or private corporation. When we are thinking about culture, what are the kinds of things that we're talking about? Culture and population and identity diversity can include many different things, such as race or class, and particularly now there has been more discussion about gender identity and sexual orientation. And while some of this information is factual and important, we also have to focus on some of the process-oriented concepts and tools that serve us when we build relationships with members of these communities, not only in our home, but in our local agencies. These concepts have become focal in Healthy People 2020 as they define health disparities among different populations. As we know, health disparities are a particular type of health or physical difference that's closely linked with many social, economic, or environmental disadvantages. Many of the social determinants of health that have been identified are things that we see among individuals in recovery, including mental health, disability, or any cognitive or sensory issues that people might experience. What's also important, though, is in Healthy People 2020, we've identified that gender, sexual orientation, and gender identity can be very influential on an individual's health and mental health. Many of these same principles are found in SAMHSA's 8 dimensions of wellness, which you see on the current slide. We find that between emotional, financial, and social issues, all of these dimensions can be affected by culture, including gender and gender identity and sexual orientation, and can all affect an individual's physical health and wellness, as well as their mental health and their recovery. So why sexual wellness and gender expression? Well, there are a number of reasons that this is very important. First and foremost, whole health and wellness implies that individuals are living balanced lives that encompass both their expression of their gender and their sexual expression. This is not only something that would affect individuals who are considered sexual minorities, such as gay or lesbian individuals, but it also affects the sexuality and the reproductive wellness of individuals who are in heterosexual relationships. These personal choices are very important for individuals' well-being as well as their self-determination. Yet often there are obstacles that prevent people from learning about their sexual orientation, expressing their gender identity, and certainly feeling safe in areas where they can talk about this openly and without stigma and discrimination. This includes psychiatric rehabilitation and other community mental health programs where sometimes service providers don't feel as equipped as they might be to understand people's diversity and how they might be supportive in these discussions. One of the things that we have to remember about privileges such as being of a racial group that might have more power or being a member of a group based on gender that might have more power is that there are privileges related to gender and gender conformity, like many of our other privileges of culture. So in order to promote more comprehensive wellness and recovery, it's really essential that psychiatric rehabilitation and other community mental health service programs include gender in the context of how they approach individuals and how those individuals identify and express themselves in their lives, and in this case, at work. We are going to be using several terms during our discussion today, and we thought we would just take a moment and identify what some of those are. As you can see at the top, we have LGBTQQIIAA+, which is really any combination of individuals who might identify as lesbian, gay, bisexual, pansexual, transgender, transsexual, queer, questioning, intersex, intergender, asexual, or as an ally. Generally, when people use the term gay, they broadly mean individuals who are in same-sex relationships. Among men, gay is typically the term to refer to men who are included in relationships with other men. Lesbian is a term that's typically used for a woman who is emotionally, romantically, or sexually attracted to other women. There are also individuals who identify as asexual, and these are individuals who generally do not experience sexual attraction, or at least do not really explore their sexual attraction to other groups of people. It's important to remember that asexual individuals often have made a choice that they do not want to participate in sexual behaviors, and that choice can be as valid and as meaningful to individuals as people who elect to be in heterosexual relationships or who elect to be in gay, lesbian, or other non-traditional relationships. The genderbread person can be an excellent handout to use with your teams and other individuals as you discuss these issues of gender and sexual orientation. One of the things that you can see here is that these terms mean different things to different people. Gender identity, for example, the arrow here is pointing at the brain because of the way that we think about our gender in a much more cognitive and symbolic type of way. Below it, you can see a yellow bar, which relates to how we express that gender, which is a much more behavioral type of manifestation. People often show feminine types of behaviors as well as masculine types of behaviors. I think most of us would probably admit we show a little bit of both, depending on what the situation is or where we find ourselves interacting with other people. Some individuals who display both highly masculine and highly feminine traits identify as androgynous in their gender expression. Our biological sex, here in the purple arrow, is really what we're born with. What's our chromosomal makeup? What types of reproductive structures do we have? And how do our bodies develop at puberty? Here, our biological sex and our gender identity and the ways in which we feel masculinity or feel femininity or concepts of being a man or being a woman are not always aligned for some individuals. Transgender individuals have a gender identity in that their feelings of their maleness or femaleness are often opposite to their biological sex. Sexual orientation, the red line at the bottom, is actually very different. Sexual orientation identifies our attraction to individuals who are the same or the other sex, or for some individuals who identify as bisexual, whether they're attracted to people of both sexes. The important thing to remember is that most individuals who are transgender do not necessarily identify as gay or lesbian. Their sexual orientation is quite separate from their gender identity. In the United States, approximately 3.5% of the population identifies as lesbian, gay, or bisexual. About 0.3% or less than 1% of the population currently identifies as transgender. Younger individuals are more likely to report same-sex behavior as attraction. For example, among individuals 18 to 29, 6.4% are likely to identify as LGBT, although among seniors or individuals over 65 years old, only about 2% identify as sexual minorities. We also find that lesbian, gay, bisexual, and transgender people are more likely to be residents of some of our largest U.S. cities, such as San Francisco, with 6% of the population, Portland, Oregon, with just over 5%, and individuals who live in Austin, Texas. There also is a tendency for individuals who are non-white to be more likely to identify as lesbian, gay, bisexual, or transgender. About 4.5% of African Americans identify as sexual minorities, and about 4% of Hispanics and Asians also identify as sexual minorities. About 3% of white Americans identify as LGBT. Overall, nearly a third of LGBT identifiers are individuals who are non-white, compared to only 27% of non-white individuals. Many GLBT people feel that health practitioners' attitudes toward them and their sexual identity can often be negative. One of the things that many LGBT people report is that healthcare providers assume that they're heterosexual, and they don't ask them questions about whether they are in same-sex relationships or whether they have past experience in same-sex relationships. In addition to their individual experiences, many GLBT individuals have reported some factors related to the service systems where they find themselves. Legal discrimination against this population can often be common, including health insurance, employment, housing, marriage, adoption, and even retirement benefits. We lack laws that protect against bullying GLBT individuals in schools or programs that are targeted for youth, adults, or elders. We also have a shortage of healthcare providers who are knowledgeable and culturally competent about LGBT health and mental health needs. And like many other individuals, transgender individuals are even less likely to have health insurance than heterosexual or lesbian, gay, or bisexual people. Like Healthy People 2020, many social justice factors affect the experience of LGBT people. One thing that this population frequently describes is that they experience stigma and discrimination because of their sexual orientation or their gender non-conforming status. LGBT people are more likely to report experiencing higher levels of violence, victimization, and harassment compared to heterosexual individuals. Gay men and lesbians are also less likely to be parents than heterosexual people. But when we look at outcomes related to the children of LGBT parents, we find that the outcomes for those kids are as positive as those that we see in heterosexual families. This includes adjustment, physical development, and other forms of physical and mental health outcomes. LGBT health issues also can be affected by their minority status. Compared to heterosexuals, LGBT individuals are at increased health risks in a number of areas. One is that this population is more likely to smoke, almost 2.5 times as likely to smoke as people who are heterosexual or individuals who identify as cisgender. LGBT people are also more likely to drink alcohol, with one study documenting that drinking 5 or more alcoholic beverages in a day was reported by 40% of bisexual individuals and gay and lesbian individuals compared to heterosexual adults. These individuals also experience higher rates of sexual and physical violence compared to heterosexual individuals or cisgender individuals. Healthcare discrimination is something that we've also talked a lot about in our communities. For individuals who are GLBT, we see healthcare discrimination and some things that we really must address in our service programs. For transgender individuals, close to 19% reported that they had been refused care due to transitioning or being a gender non-conforming individual. 28% had been subjected to some form of harassment in a medical setting, and even 2% of trans individuals reported that they had experienced some form of violence in a doctor's office. Among lesbian, gay, and bisexual people, close to 35% of those individuals living with HIV in one study said that health professionals refused to touch them or used excessive precautions for their illnesses that they wouldn't have used with other individuals who had equally contagious illnesses. Close to 26% said that they were blamed by a medical professional for their health care status. Substance use also can be higher among LGBT people. We see higher rates of suicidal ideation, suicide attempts, mood and anxiety disorders, and especially depression. We see higher use of tobacco and alcohol and other substances, and among transgender adults, substance abuse is even a higher concern. We do know, however, that substance use is often under-recognized or undetected among LGBT adults. Some report that they use alcohol and other drugs to feel better in stigmatizing or discriminatory situations, and it helps them try to pass as heterosexual, further perpetuating their invisibility as an at-risk population. Substance abuse treatments, especially ones that include prevention, are important for LGBT individuals overall and are especially important for young people who are coming out or trying to explore their gender identity. Individuals who are transgender also experience mental health challenges. In one study, 13% were denied treatment at mental health clinics. Almost 41% of individuals who are transgender report that they have attempted suicide, 25 times as likely to attempt suicide than the general population. They also report more use of alcohol and drugs to try to cope with mistreatment, and 18% reported that they have used alcohol or other drugs in order to feel better and less stigmatized or discriminated against in their communities. Now I'm going to turn things over to my colleague, Nikki Pashka, who's going to talk to us more about some of the differences between gender identity and sexual orientation. Oftentimes, these terms are used fairly interchangeably, but as we've learned, they mean very, very different things.
Thanks, Lisa. One of the biggest reasons I think folks get really confused about the difference between gender identity and sexual orientation is because it is often all lumped together in the LGBT slogan and phrase that we hear thrown around a lot, when in reality, gender identity and sexual orientation mean very different things. Gender identity has a tendency to lean more towards our social experience of our wellness, whereas our sexual orientation is a term that's going to speak more specifically to the individuals we are attracted to or want to spend time with. So gender identity is our feelings about our gender, how we feel about and express our gender. We express our gender identity in a way that we act, whether it's masculine or feminine, neither, or both. Gender is our social and legal status as girls and boys, men and women. Culture determines gender roles and what is masculine and feminine. Our gender includes a complex mix of beliefs, behaviors, and characteristics. Do you act, talk, and behave like a woman or a man? Neither, somewhere in between. Are you feminine or masculine? Both. How you dress, how you walk. These are questions that help us to get at the core of what our gender is, what it means to us, our gender identity and expression. Sexual orientation is a term used to describe whether a person feels sexual desire or romantic attachment to or for people of another gender, the same gender, or both genders. Each of us has a sexual orientation. You may identify as bisexual, gay, lesbian, or straight. You may be questioning, but sexual orientation is who we find ourselves romantically or sexually attracted to. It's much more external than gender identity. One of the reasons I think individuals who are service providers get confused about the difference between gender identity and sexual orientation and the sexual wellness needs of the individuals we serve is because, generally speaking, here in the United States, we have not been educated well enough on this topic at all. As you can see here on the screen, and these are very current statistics and current information, different states have the option of what they present to young people when they're learning about their own sexuality. We have highlighted here Illinois, and you can see that while there is HIV education mandated, it must be medically accurate and age appropriate. However, it does not need to be culturally appropriate or unbiased. See some of the other states here on the slide, like Indiana, for example, where while you have to provide some information about HIV education, it does not need to be medically accurate or age appropriate. So depending on what state you live, when you received this education, who you received the education from is going to change dramatically how you feel about your own sexuality, your own gender identity, and your own orientation. We know very well that that information transfers immediately to the individuals we serve, whether we're aware of it or not. Many of us as service providers spend a great deal of time, or should spend a great deal of time, learning about ourselves and our own opinions about sexuality, gender identity, and orientation before really engaging with other members that we serve. The term cisgender refers to people whose gender identity and their gender expression correspond with the sex they were assigned at birth. This term denotes the opposite of individuals who would use the term transgender. Now, the term cisgender is a means of accounting for privilege and trying to counteract the tendency to only name that which is different. However, some activists feel it only functions to reinforce the gender binary. Cisgender truly identifies the majority of our population. However, if you ask a person who identifies as cisgender if they know what cisgender means, it's likely this is the first time they've heard that term. Transgender is definitely considered an umbrella term or an all-encompassing term. Trans-identified individual or transgender people have significant gender identification that is different from the sex they were assigned at birth. Transgender is an umbrella term that includes a diverse group of people who transgress gender norms by challenging social constructs of gender. Social expectations of gender vary by culture, geographic location, and generation. You may hear additional terms like trans man, trans woman, and this all just denotes in which direction on the binary the individual transitioned from. We also want to talk about individuals who identify as gender non-conforming. These individuals reject the binary altogether. They are neither identifying as entirely masculine or identifying as entirely feminine. Some of them won't even identify as androgynous. They're somewhere in the middle. Gender non-conforming individuals have a gender presentation that differs very widely from widely accepted and prescribed gender expectations. So this might look like an individual wearing a suit who identifies as a man, but perhaps is wearing nail polish, or a woman who definitely identifies as female and is typically expressing themselves in a feminine way, but elects to wear pantsuits or more masculine identified clothing. So these individuals don't identify with one side of the binary or the other. They identify somewhere in between. Something I like to remind people is to check yourself before you wreck yourself. We all heard these terms back in school, perhaps picked it up somewhere in a magazine, but I think we should spend some time really unpacking the difference between stereotypes, bias, prejudice, and discrimination. Stereotypes are an oversimplified image or statement applied to a whole group of people without regard for the individual. A bias kicks that up a notch and brings in attitude or beliefs or a predisposition to see events, people, or items in a positive or negative way. It skews how we think about that particular thing or person. A prejudice is an unfavorable opinion or feeling formed beforehand without knowledge, thought, or reason. Oftentimes, feeling prejudice towards something is very subconscious, and most individuals are not aware of this at all. Discrimination is the practice or the act of unfairly treating a person or particular group of people differently from other people or other groups of people. Again, this is a oftentimes very subconscious or behavior that individuals don't know that they're doing when they're doing it. So one of the reasons we want to learn more about these particular terms is so we can help call out our peers and friends and coworkers when they're engaging in any of these activities without them knowing it. Homophobia, for example, is the fear, aversion, or discrimination against homosexuals and/or homosexuality. I'd like to pause here and say that homosexuality or homosexual isn't exactly a friendly term these days. Identifying somebody or asking somebody if they identify as a homosexual may put somebody on the defense. Instead, try asking the individual how they identify and use that word when engaging with the individual, especially if we're thinking about these terms in the workplace. As an employer, if you're supervising individuals, you never want to label somebody with any of these terms without asking the individual how they would like to be identified. So here we see homophobia including things like beliefs and actions directed at the gay, lesbian, and bisexual communities, or specific individuals, or even spaces that tend to be more occupied by the LGBT community. Transphobia is a hostile attitude or feeling against people who identify as transgender or gender non-conforming because these individuals push and manipulate social gender norms. They threaten the non-gender binary, and individuals who are very invested in the gender binary can become very frightened and or angry when the binary is challenged. Oftentimes, folks will express that they feel confused why people can't identify as one or the other. It's how they were made. So these end up manifesting into a very defensive, threatened vibe that puts individuals on edge, and then we see them lash out and act in bias and prejudice ways, and that is transphobia. Cis-sexism, say that 6 times fast, is a system that enforces the gender binary and oppresses those who are gender variant or transgender. Now, cis-sexism is particularly hard to see or observe if you yourself identify as cisgender. It may take you a little while to point out some of your own behaviors that might fall into this cis-sexism category. It is the assumption that one's gender is determined solely by their genitalia at birth, rejecting everything we just talked about in terms of expression and identity. Cis-sexism does not recognize that some people's lack of gender binary and or could be intersex. It promotes the idea that people who are transgender or gender variant are inferior to cisgender individuals. Unfortunately, we are all socialized to be cis-sexist. I like to ask individuals of all backgrounds, when did you first notice or know when you identified as cisgender? Many individuals who consider themselves sexual minorities have a coming out story or a situation where they knew that they identified as gay or lesbian, or they knew that their gender expression was falling outside of the binary. But I don't think individuals who identify as cisgender are asked this question. So this is a fantastic exercise to do with your staff and a team meeting and supervisions, but having conversations around when did we first learn and identify this way? Intersectionality is a concept that is pulled from academia. It's pulled from really intense critical theories that are used to describe the ways in which oppressive institutions, things like racism, sexism, homophobia, transphobia, are interconnected and cannot be examined separately one from another. This concept first came from the legal scholar Kimberly Crenshaw in the 1980s and is largely used in critical theories, especially feminist theory. There was also a lawsuit that happened where at General Motors, it was identified that if you were a Black woman, there was no jobs available to you. Jobs were segregated whether you were male or female and Black and white, and at the end of the day, they realized there were no jobs for Black women. Of course, they won this case, and intersectionality has become more and more obvious and more brought up in the public eye, but it is a very delicate conversation that we all need to start having more and more. Microaggressions are brief and commonplace daily verbal, behavioral, or environmental offenses, whether intentional or unintentional, that communicate hostile, derogatory, or negative slights and insults. Now, microaggression typically is used in academia in a very academic sense, but more recently this has moved into the public eye and certainly into our world as social service providers. This could come across as treating individuals or making them feel to be second-class citizens, assuming inferiority or pathology of marginalized identities or cultures, denying personal bias, cultural blindness. Whatever the fact, they are oftentimes unintentional. They are behind the scenes. They are very quick. They are microaggressions. Now, it's very common in the workplace to display little items of your own personality or identity. We put up little toys and pictures of our spouses, our children. We express ourselves oftentimes in our workplace setting. A personal story that I can share with you is when I started a new job and I was very excited to put out my toys and my photos. And the day I did this, my supervisor comes over, looks at my photos, which were my wedding photos. Full disclosure, I am an individual who's married to an individual of the same sex. My supervisor looks at that photo and says, "How did you decide which one of you would wear the dress?" Now, outright, that's not horribly offensive, and many of you are thinking, "Nikki, why are you so offended?" But truthfully, that implies that she doesn't know very much about sexual orientation and gender expression. It's beyond possible that both of us could have worn dresses or both of us could have worn suits, but she was curious how we decided one of us would wear a suit and one of us would wear a dress. Many folks say they don't mind individuals that are gay, they just don't want it pushed in their face. Why is my photo of my wedding with my same-sex partner any more threatening than a photo of a heterosexual man and a heterosexual woman's wedding? Microaggressions hold their power because they are invisible, and therefore they don't allow us to see our actions and attitudes may actually come across as discriminatory. As social service providers, it is our responsibility to identify microaggressions and decide what part we can play in resolving these commonplace negative slights and insults. One way to start engaging in these conversations that are oftentimes very difficult is to develop our own cultural mindfulness. We are moving away from conversations that we would traditionally call culturally competent because cultural competency implies that there's a crown or a trophy or a finish point to learning about and exploring other cultures. We know that it would be impossible to learn everything about every culture and learn about that person's experience within that culture. So instead, we encourage individuals to engage in cultural mindfulness. Now, definitions commonly emphasize being attentive or really in the moment, paying attention to every nuance and detail, from how the room is laid out to what you're wearing. We also want to present ourselves in a non-judgmental way. We want to be very open, asking less questions. And as clinicians, this can be very difficult. We like to ask a lot of questions. What helps this is by acting intentionally, thinking very critically about what you say, how you say it, and when you say it. Other core actions of the culturally mindful include being aware. I mentioned the room or the space. As clinicians, Hopefully, we're very aware of where we are at any given time, whether that's meeting with a client or member in a car, meeting with somebody in a very small room, meeting with somebody who perhaps has experienced trauma and is our space trauma-informed. Other actions of the culturally mindful include being plugged in. This means tuning out all other noise. If it's not in the room, if it's not between you and this individual that you are developing a relationship with, it's probably not worth buzzing around in your head and you should push it aside. We also want to be affirming. Thanking individuals for being open, repeating things back to them that make them feel heard, that you are listening. And of course, at the end of the day, if we want to be culturally mindful, we need to develop better skills to self-evaluate, to think about what happened in certain sessions or situations that perhaps could have been phrased or dealt with in a slightly different way. Could you be more trauma-informed? Could you be more open and less, say, sex negative when you could have been sex positive? And we'll talk about that a little bit later. But all of these items, being aware, plugging in, being affirming, and self-evaluating, make an individual much more culturally mindful in the moment. Now, I know what you're thinking. It sounds very complicated. How will I ever do this? Well, we need to improve our skills in noticing the behaviors of others. Again, not just what they say, but how they say it. A common mistake that clinicians make is trying to force really clinical language on top of something that is just a human conversation. So if an individual is more comfortable using slang, let them use slang. It's going to move you through that conversation and that rapport building much easier. It's important to be open to novel or unfamiliar behavior without evaluation. Catch yourself judging. Catch yourself developing stereotypes or honoring stereotypes that you have in your head. That's a part of the cultural mindfulness piece we just spoke about in terms of self-evaluation. Try to fully use your senses to take in small details and other nuances and stay attuned to them. Body language will tell you so much more oftentimes than the words coming out of an individual's mouth. Allow yourself to be curious, especially with regard to the cultural context of the other, and try to connect with the other inside their framework. Is there some aspect of their culture that also exists within you? Trying to see ourselves in the eyes and experience of other people will help us achieve common ground. Above all else, it is imperative that you come to this relationship, that you come to this work being humble. We are all going to make mistakes. We are all going to accidentally mislabel or use the wrong pronoun. It's important to apologize for that mistake or that flub and move on. Be humble. Be part of the experience. I know what you're thinking. It seems really complicated, but I assure you, we have the skills to do this.
Thank you, Nikki, for that important information about some of the ways that we characterize gender, sexuality, and sexual orientation. These are really important concepts related to people's mental and physical health, and it's especially important that we think about them and the ways that they affect our lives at work and our work identity. As all of us know, work offers more than just a paycheck and the opportunity to earn money. It's one of the ways as adults that we build our skills, we present ourselves, we make new relationships, we form social networks, and we contribute to the communities that are around us. There are many reasons that people elect to work and have a relationship with their employer and the other employees or their peers. Work is an essential ingredient to our well-being, as we know that it promotes some of the most positive things in our society. Quite obviously, work, even part-time work, reduces poverty, but it also reduces social isolation and promotes these positive relationships with our peers. It reduces anxiety, depression, and in many cases, alcohol and other recreational drug use. Work for individuals with disabilities is particularly important because oftentimes working reduces their dependence on benefits, the use of entitlements, and other often shifting public support systems that can be vulnerable to policy changes, that can have time limits, or that can have exclusion criteria that can affect people. It's important to remember that as adults particularly, work is perhaps considered one of the most singly considered a normative activity of life and how we spend and structure our days. When we meet individuals at social gatherings or family events who are new to us, one of the first things we say is, "Hi, I'm Lisa. I'm a psychologist." We tell people who we are and what we do. And if we don't have that opportunity, sometimes we can feel badly, we can have negative responses, or we feel like we don't have a way to connect to other people. Supported employment as an evidence-based practice is one of the most essential ingredients in all of the community mental health services that we provide. As most of us know, supported employment has an enormous amount of research that has been conducted by it. More than 25 randomized controlled trials and scientific research have been conducted with this model. Some of the components that are most effective and most essential to us are promoting self-determination, using person-centered planning, the idea that no one who's in recovery or has a disability is completely unemployable, that we can support people in models that are the right match and put them in work settings that they like, and that they can develop skills in their recovery that can change over time. Especially with our young adults and youth who are in our service programs, it's important to remember that they're at the beginning of their careers in the workforce. Some of the needs and desires or things that they want might be very different from someone who's in their 40s or even is at the end of what might be considered their time in the workforce. The ways that we support them and the things that we offer them to ensure that their employment experiences are successful can often be very different. One of the most important things we've learned about employment and health from research on individuals with disabilities is that some of the things that they experience are very different from us. We looked at some data at the end of last year about employment rates, and what we found was that about 19% of individuals with disabilities are participating in the workforce. Unemployment rates among individuals with disabilities and chronic health conditions are higher than the national average at 10% compared to just 5%. Employment participation by individuals in the general population is 3.5 times as high as individuals who live with disabilities. And the unemployment rates, as we noted, are more than twice the rate of individuals who experience disabilities and chronic health conditions. This reminds us that workforce participation by individuals who do not live with disabilities or health conditions sometimes can be easier because of their health, but oftentimes can also be easier because they're in an environment that's more supportive, where people have the same experiences of them, and they're not separated because their coworkers are not as informed or not as experienced with what it might be like to be living with a disability and how your life in the workforce might be a little different. This is also true for individuals who are gender non-conforming and individuals who are sexual minorities. Among transgender and gender nonconforming individuals, they have almost double the unemployment rate as individuals in the general population, so their experiences might be very similar to people with disabilities. More than 90% of people who identify as transgender reported in a national study that they experienced some form of mistreatment or discrimination at work, and as many as 1 in 4 reported that they had lost their job as a result of their gender identity. Among lesbian, gay, and bisexual individuals, about 40% are unemployed at any given time. 16% have reported that they've lost a job because of their sexual orientation, and as many as 35% report that they have been harassed or had some form of maltreatment in the workplace.
It goes without saying that there are limitations of the binary. However, limitations in the binary come out in full force, I think, in the workplace. For example, there are jobs that we feel as a society that are more appropriately filled by men than filled by women. If I asked you to think about, in your mind's eye, what a construction worker looked like, you probably just populated that image with a husky-looking man in an orange vest. If I asked you to think about, in your mind's eye, what a nurse looked like, you may populate that image with a female form. We also see limitations in pay scale for individuals who identify as female over individuals that identify as male. It's no surprise or secret that to this day, individuals who identify as male are paid more for the exact same job that their female counterparts would also do. Space, dress code, and restrictions all really feed back to this binary. So for individuals who don't identify as male or don't identify as female or are making a transition from one side into the other, the workplace oftentimes ends up being a very hostile and treacherous area for them to navigate.
It is important to review in your home state what types of employment non-discrimination laws are true. There are 20 states that have employment non-discrimination laws for sexual orientation and gender identity. That's 20 states out of 50 states. 3 states have laws that only cover protections for individuals based on their sexual orientation. There are 28 states that have absolutely no laws preventing employment discrimination based on gender or gender identity. 2 states have laws preventing passage or enforcement of local non-discrimination laws. So the important thing to remember now is, based on the Supreme Court decision on marriage equality, you can get married in the morning in some places, but be fired that afternoon if you register and fill out paperwork to put your same-sex spouse on your health insurance. Here we have a simple map of the United States that shows a snapshot of some of the non-discrimination laws that we see related to gender and gender identity. If you see a state that's dark green with a T, this is a state that has employment non-discrimination laws that encompass both sexual orientation and gender identity. That's 19 states and the District of Columbia. The light green states have employment non-discrimination laws that cover sexual orientation only, with some federal protection laws against discrimination. The white states pictured here have no employment discrimination laws that cover sexual orientation or gender identity, despite some of the federal protections that those individuals will experience. The yellow states, with an exclamation point and a caution sign, are states that have laws that prevent the passage or enforcement of local non-discrimination laws. So it's important to remember that individuals who are sexual minorities or gender non-conforming individuals often have to be very careful where they're working or how their employer might view their sexuality or gender identity, because it can affect their positions there. One of the things that we all must focus on is what we call a call to action in some critical areas that we've identified to improve our systems, both in health, mental health, and certainly employment. Some of the things that we feel are really important to focus on in building these programs at your agencies and service provision locations is to think about the ways that violence, and including homicide, can affect LGBT communities. Certainly recent events at a nightclub in Orlando, Florida, brought to the nation's attention some of the hatred and discrimination and often rage that gay, lesbian, and bisexual and transgendered individuals experience, and some of the violence that from some people can be a result of these views. Nationally representative data that looks at health and health care among LGBT Americans is critically needed, as well as a model of wellness that focuses on LGBT needs and priorities. We need to look, as we do in communities of recovery, on resilience among people who are sexual and gender minorities. Think about the ways that their life course, their parenting experiences, their health as elder or geriatric types of populations might be affected by their gender identity or sexual orientation, and certainly recognizing the medical needs as individuals who are transgender are really necessary and vital to their health and mental health, not elective procedures or things that they can pick and choose to do. Something critically important within our service programs, whether it's about gender or sexual orientation, is to remind individuals about the positivity of sexuality and gender. One of the ways that we can do this is to reframe sexuality in a more positive and recovery-oriented framework.
Over the last couple of decades, we've done this pretty successfully in the mental health field, moving our theories and thoughts about mental health from ideas of illness and fear and pathology and instability to ideas of recovery, hope, and empowerment. We're looking to do this in a much more strong way with sexuality, moving it from the idea of only talking about sexual dysfunction or sexually transmitted infections, things that are based in fear and danger, and moving that towards sex positivity, things that understanding that sexuality is a basic human right, that expression and choice are just as critical, having openness, using inclusive language. Again, we've done this already or are continuing to do this in the mental health field. It's time now to make this advance in the world of sexuality and sexual wellness. As clinicians, we're always working on improving our listening and rapport building skills. When we're having conversations about sexual orientation, gender identity, it's clear that there's going to be some sensitive information shared, and this is why having trauma-informed services will help us navigate these treacherous waters. Motivational interviewing is a fantastic modality that offers different skills like reflecting and reframing, which can help us avoid shaming individuals when they bring up more sensitive or non-norm information. We want to move to a school of harm reduction, and it's imperative that to fully understand sexual health, counselors specifically need to comprehend not just sexual functioning, occurrence or absence of disease, sexual activity and choices, but how sociocultural factors such as poverty, gender roles, sexual identity, access to care, and education impact oneself. Other easy ways that service providers and programs can make a more inclusive space would be to onboard this idea of safe zones. Now, this is a nationally recognized initiative to develop and announce inclusive space. It could be a rainbow flag or one of the more traditional icons, but posting these non-discrimination photos and materials help reinforce that your agency also has non-discrimination policies and generally are a more inclusive and affirming space. Every staff person, not just clinicians and those who have face time with clients or members, need to be trained in diversity and cultural mindfulness. This means everybody from the person who is perhaps the administrative assistant at the front door to any of the custodial team members, anyone at your workplace needs to be trained in cultural mindfulness and diversity. The electronic health record, or EHR, is another fantastic place, though admittedly can be more difficult to navigate as with funding and specific computer programs may not allow for a lot of flex and flow and how things are written. But if you are looking for something frustrating to do, I definitely recommend looking at your EHR and seeing how you can make that more inclusive. Events and other continuous trainings are great ways to embed these ideas into your programs, perhaps having a mindfulness committee or a specific group of people. Supervision, team meetings, always a great opportunity to put your minds together and think about how can we create a more inclusive space, who are we leaving out, and of course, if you're going to make a referral, please vet those referrals. Send a staff person to, say, the HIV testing center in your city, because it may not be as inclusive as you think it is. Or if someone is going to make a referral to go to the GLBT center in your city, perhaps suggest that a staff person accompanies the client. Make sure you test and vet your resources and referrals before offering them to your clients. One easy area where your agency can spend more time thinking about how inclusive their policies and procedures are is by examining the electronic health records. Multiple EHR, or electronic health record systems, with different mechanisms and lack of mechanisms to capture things like gender or sex and legal name. Many agencies only have the opportunity to put in data that is the name or sex that is listed on their passport or driver's license, and often has to resort to putting their trans-identified name in parentheses or in a bracket or handwritten on a file. We need to further develop these systems so that we can be sex positive, so we can have an inclusive lens. There need to be specific workarounds embedded into the vintage electronic health record systems that we have. We do recognize that there are some state or agency-specific requirements for billing, but again, thinking about workarounds or other inclusive ways that we can collect this data and share this data while still affirming individuals that fall outside of the binary or identify as sexual minorities. Engagement problems, perhaps the biggest problem we see in social services. For individuals that identify as sexual or gender minorities, access to mental health services and the quality of the services they receive are negatively affected by the lack of cultural competence and service delivery. Many research studies have shown that because of the lack of cultural competence, people of color may not seek out services, and certainly gender and sexual minorities, they're not going to be seeking out services in the formal system. They feel like they can't trust the formal system. They're going to drop out of care. They're going to fail to return. And the next time you're going to see that particular individual is unfortunately when their illness is in an advanced stage.
The most important thing is to remember that all of us can be part of the problem or part of the solution. What's really essential is in our service programs, whether they're about recovery, about health, and certainly about employment and our rights as workers, we have to serve as role models and inclusive individuals who can help be part of the solution for individuals who are seeking to go back to work, who are GLBT, who are gender non-conforming, and who seek to have the same opportunities to benefit their life and advance them as anyone else in our country and our communities. We have some additional resources that we've included, including some reports from the Institute of Medicine, Healthy People 2020, a joint field guide on GLBT and gender minority health, and certainly a health report on sexual minorities and public health perspectives. We would invite you to take a look at these materials and to learn more and have discussions within your service programs with in-service training, workforce training, or other ways that you improve the knowledge, skills, and affect attitude change among the providers with whom you work. Additional resources can be found regarding LGBT women in America from the Femway Institute and the National Center for Transgender Equality. Thank you for listening today, and for more information, please feel free to contact us with the information below. Thank you.